Welcome to the American Shoulder and Elbow Surgeons Podcast. I'm your host, Brian Waterman, a sports and shoulder surgeon at the Wake Forest University in North Carolina, and I'm joined by my co-host, Dr. Peter Chalmers today. Peter, welcome to the podcast.
Oh, I'm so excited to be here.
Before we get started, I should mention that the views expressed in this podcast do not necessarily reflect the views of the American Shoulder and Elbow Surgeons Society, University of Utah, Wake Forest, or any of the institutions of our guests. So we have the great pleasure today to really dive in on several abstracts that will be presented at the 2025 meeting of the ASES. We've got a great list of content, and this is going to be part 2 of our series looking at individual studies with our presenting authors.
Yeah, we're very excited to be here. We had just a phenomenal set of interviews. Hopefully you guys enjoyed the last episode, and this will be more great talks from the ASES from our annual meeting.
Joined today by Dr. Min of Island Orthopedics in Hawaii, who's going to discuss his paper, Anterior Glenoid Reconstruction versus the Open Latarjet in the Treatment of Shoulder Instability with Anterior Glenoid Bone Loss at Midterm Follow-Up. Dr. Min, welcome to the podcast.
Thank you for having me. It's an honor to speak with ASES.
And not to be upstage, but joining us as guest hosts, the good Dr. Navarro from Kaiser in Los Angeles. Dr. Navarro, thanks for joining us on the podcast.
Thank you guys for having me.
All right, Kyong, so tell us what inspired you to do this study?
Being in the military for most of the study, we see a lot of instability, and I saw a lot of it in my training. And seeing my predecessors like Dr. Arthroscopic and Dr. Tokish and all those guys that have done great shoulder instability research, I thought it was an opportunity that I can really help the community out in terms of the military community and also hopefully the rest of the world, and providing just newer research and innovations on how we can treat people better.
And so frame out the study for us. Can you describe it?
So a lot of it just started with teachings from fellowship. So Dr. Galvin and I did the same fellowship. So we had a lot of trainings from Warner and Higgins talking about make sure you collect your data, make sure you follow in your patients, and try to get patient-reported outcomes before and after if you can. So that was the whole premise of what we did. And Joe Galvin, he's just a great researcher, and he set the premise getting all the IRB paperwork approved for both institutions so that we can collect data and really look at how things are going. And I think you can see from our follow-up on how our practice has changed on the various procedures that we're doing. So the idea was to collect data, do the best we can, and let's figure out what's the best option for our treatment options for our patients.
Great. So study collected from you and Dr. Galvin, and tell us what you found.
So it was surprising because we grew up, when I say grew up in fellowship, we were trained to believe the Latarjet is the everything for shoulder instability, and we still do believe that. But what we found that is when we compared our cohorts between the Glenoid reconstruction, the free bone graft versus Latarjet, they're very equivalent, which is similar to what Philippe Moudor found out in 2019 and also on his follow-on studies. So the overall clinical outcomes are very similar between the Latarjet and also the anterior glenoid reconstruction for patients with anterior glenoid bone loss, about 20%.
So similarly good, similarly bad. Tell us, what does that mean when you say they're similar? What is the recurrence rate for both those groups?
So in our cohort, we had 23 in the anterior glenoid cohort and 39 in our Latarjet cohort. And we showed that the dislocation rate was similar. So we had about 3 dislocations in the Latarjet group, 2 to 3 dislocations, I believe, in our AGR group. Subluxations were actually a little bit higher on the Latarjet group, but that's all something that we're asking the patients on how they felt about it. The SANE scores was about 70 to 75 on both groups, and also the ASES score was right around 80. So from a patient-reported outcome standpoint and also from a recurrence standpoint, they're very similar. So similarly good.
Talk to us about complications.
Complication-wise, fortunately for us, most of them were very minor. We had 3 complications per group. No permanent injuries, but we did have some where they had to be revised because of bone resorption, or we had some superficial infections. I had one patient that had a deep infection that required multiple washouts, but again, they're very similar. And we didn't have, fortunately, any the big nerve injuries.
Kyong, really great study. I want to dig into the satisfaction piece. You pointed out that 91% satisfaction in the free grafts and 67% in the Latarjet. Can you hypothesize us the reasons why there's that discrepancy?
That's a Great question. It's something I was actually talking about with Dr. Galvin this morning over coffee. We think it's because as we've gotten better with these procedures, and our patients are very active. They're competitive. We'll consider contact athletes. The military soldier is very similar to that of a football player or rugby player, and they're stable, but it doesn't feel normal. I think that's where it comes down from. So when you're having dislocations while sleeping, if you give them a stable shoulder, they're going to be very satisfied. But if you have dislocations in contact sports where it just in the apprehension position, and then you stabilize those, they're happy, but it may not feel normal for them. So I think they're satisfied, but it doesn't feel normal. And I think that's where the discrepancy comes in, because we could tell that they don't dislocate much in the Latarjet, but I believe the argument is the AGR feels a little bit more natural. Maybe it doesn't feel as check rein-like with the subscap sling. I think the subscap sling gives them a check rein feel, which gives them the stability, but doesn't feel normal.
Yeah, and I was wondering just about that residual pain from the harvest site of the coracoid away, and that was my thinking too, that patients just don't feel normal from that perspective too. You've changed a piece of the normal anatomy to some other different place, and that may be a part of it. Cost benefit, free graft is costly, but there's decreased satisfaction with the Latarjet like we just spoke about. So kind of which solves the value equation, really?
That's a really tough question. I haven't done the dollar amount cost analysis. One way to get around that is instead of doing a allograft reconstruction, we could always do an autograft. So obviously JT Tokic has shown that the distal clavicle is an option. Also, you go back in history and still do the iliac crest, which I would argue is still probably the gold standard. That's what Philippe Modor showed in his study. They were the autograft. Now, there are obviously downsides to that as well. So I think if I'm in an institution where cost is a big issue, then I would strongly consider that. On the flip side, if I'm in an institution where cost is less of an issue and I want to cause less morbidity to our patients in terms like if you're like a collegiate athlete that has only so much time and they don't want any hip pain from the iliac crest harvest, I think we can make the argument that for those patients, the cost of an allograft is probably more beneficial. Now, I haven't done numbers for it, but in my mind, that probably makes more sense.
It's your amazing practice at Island Ortho. We are all wondering if you could hire us, by the way, to Island Ortho. But which would you use then?
If it was, well, I think it really depends on the patient, to be vague as possible. I think I have someone that has mid-arc instability and is symptomatic when they're about to go to sleep, they're popping out, and they're also something like jiu-jitsu or things of that sort. I think I'd be a little more heavy-handed in doing a Latarjet. Versus if I had someone that's like a volleyball player that dislocates when they go for a hard spike and things of that sort, and maybe they need a little bit more proprioceptive feeling, don't want that check ring thing, I think I would consider more of a free bone graft type of procedure.
Ron, maybe I could ask you to take off your surgeon hat for a second and put on your systems hat. You come from a unique perspective, which is one of the reasons I'm really excited to have you on to talk about this paper because, working at a center like Kaiser, where obviously you're cost conscious, but you also want to do the right thing for your patients. I mean, is there an administrator that looks at this and says we should never be paying for these grafts? The outcomes are the same?
Fortunately, for the types of grafts that Dr. Min and his team were using, we don't have a limitation on that graft. So we would be able to use that graft if we went through what was a wonderful paradigm that he described to kind of discern what you'd use in which patients. We could do that easily, fortunately, in our system. But I agree with you that probably more and more we'll have to kind of do this cost-benefit analysis and see what the efficacy is over time.
I guess one question I have for you is I think you can look at these results two ways. I think one way you can look at the results is to say, Latarjet is the gold standard. This paper shows, like Moroder's study, that AAGR is just as good as Latarjet. I think you could also look at the paper to say AAGR is no better than Latarjet, so we should stick with the tried and true. Which interpretation do you take?
Neither. I think we have to look at it as it's really patient specific. I know there's always that meme talking about there's a nail and I'm a hammer and I must hit it.
Yeah.
What kind of hammer do we want to use? I think that's the way to look at it is, do I want to hit it with a big hammer or do I need a little hammer on this part? That's kind of the way I look at this situation is if I need the big hammer, then we bring out the big hammer and we do. And I think I would consider the Latarjet the big hammer. But if it's say, hey, maybe it's a situation where I don't need that, maybe something a little fine touch, I think the little hammer can help at times. And one of the reasons I'm a big proponent for the anterior glenoid reconstruction is because I could always bail to a Latarjet and do very well. And I think having that conjoint there protecting me from the neurovascular structure is very comforting. And having revised a few failed Latarjets, when you don't have that, it's less comfortable. I know the studies have shown that if you do a glenoid reconstruction after Latarjet, they can do quite well. But it does not, I don't do quite well in my soul. It's very stressful. It's very difficult. Dissecting out the plexus is not something that most surgeons can do very comfortably. So to me, if I could reserve the big guns for later, these surgeries will fail. But if I could reserve the big guns for later, maybe I have to revise a little bit less Latarjets. And I'd rather revise an anterior glenoid reconstruction that failed and make it into a Latarjet than the other way around.
And so one of the things you engage in your paper is you talk about radius of curvature, and I have a couple thoughts on this, but I'm curious what you think about implications for secondary arthritis and better containment. We just completed a discussion about constraint around reverse. Is the AAGR, does that provide more constraint that the Latarjet does not?
I don't know, to be completely honest, and I've actually encouraged my military residents to follow these guys for another 5 to 10 years. And get follow-on radiographs. So hopefully in 5 to 10 years we'll understand that. My true answer is I don't know. Yeah. Is like almost like an ACL. People that have an ACL reconstruction still get arthritis, right? We know that's faster. Is it from the initial injury or is it from the reconstruction because it wasn't perfect? I think it's the same way. Is this from the initial injury that's causing the arthritis, or is it the fact that the surgery isn't perfect and causing arthritis? Hopefully with these studies that we compare, assuming that Dr. Galvin and I did perfect surgery, I know that's a big assumption, but assuming we did the perfect surgery, we can look at our follow-on and say, hey, do our anterior glenoid anatomic reconstructions, do they have less arthritis than our Latarjet patients? And I think at 10 years it should hopefully bear out.
I think it's even more complicated than that, though, because even if you are a perfect surgeon, you don't have a perfect graft in either of these situations. Right? I think that's one, that's the piece that maybe we need to do more work on is how do you take the end of a tibia bone and make it look like a glenoid? And the answer is you can't, right? So I think you don't be too hard on yourself there, right? Because it's even harder to take a coracoid and make it into glenoid. I mean, how many times have you had, Brian, where you put it in and you're like, wow, it's really bowed in a weird way, and then you're shaping it with the burr, and I think that's a real technical challenge there that really plays into the difficulty in answering that kind of question.
Right. And so two questions, hot takes only. Sling effect, alive or dead?
I believe it's alive.
Okay, Ron?
Alive.
Okay. Future state, is Latarjet still in our armamentarium, or are we moving collectively towards a free bone block option?
I'm moving towards free bone block, but I'm never going to give up the Latarjet because to me it is the goal. It is the end all be all for instability.
Honestly, I've never done free bone block. I just use Latarjet all the time.
All right.
What about you, Brian? Which direction is your practice moving?
I think it is moving towards a free bone block, but central to that discussion is one around cost and value. And then also, I think to Ivan Wong's point, we really need to make sure that in terms of bony resorption, we're not setting our patients up for failure. So to further complicate this discussion, fixation, future state of that bone block, and then ultimately talking about secondary arthroplasty and how that's going to make it more easy for the rest of us.
And these patients are 100% screws, correct?
No, they're not. They were majority screws. There were a couple that did suspensory and 2 that did anchor fixation for the anterior glenoids.
Some variation there.
There is some variation. And we're teasing out actually, we have a cohort that we're following between arthroscopic and open for anterior glenoid as well. And we're having some interesting results with that as well. Looking to publish that soon as well.
And you didn't do or study any arthroscopic Latarjet, right? That wasn't a part of the groupings of surgery types or techniques.
No, Dr. Galvin and I, we both did open subscap. We actually did our Latarjet almost exactly the same. Open subscap where we repair the labrum, the Bankart portion to the graft itself. But no, we did not do any arthroscopic Latarjets.
And can you tell me, I know Dr. Galvin is a big distal clavicle enthusiast. Where does that fit into the algorithm on top of everything we just described, the menu of options?
For me, I look at the age of the patient for one thing, because I did one in an older gentleman, which I regretted doing. His bone was quite soft, so it made that distal clavicle portion not ideal. So I think it's something I'd consider. I would definitely measure it. Everyone's clavicle, I've just seen me do this clavicle, it's very different in size. So I'd be very detailed in measuring the length, the width, and the height to make sure. I think it's in the armamentarium, but I mean, if I'm taking autograft, I still like the iliac crest. It's such a hard, strong, proven bone. I think I would need to see more evidence on how well a distal clavicle does. But to me, if I had to choose between the two, I would just warn the patient the hip's going to hurt, and we'll take the iliac crest.
You know, your adherence to patient-reported outcomes is really admirable. And the sample size was small. I kind of geeked out with the help of ChatGPT. I looked to see a difference between the 8.7 redislocation rate in the free graft versus a 7.7 in open Latarjet. You'd need 11,000 people in each group. So my bigger question than me wasting my time on all of that is what do you think about a multi-center study to kind of help us kind of understand this further?
Well, I think that's huge. I mean, ideally, we were actually trying to get multiple military facilities to get in this. The difficulty was communication between the institutions were more difficult than you would imagine within the same government. The reason that we could, Dr. Galvin and I could get together, because I was at Tripler in Hawaii, and he was at Madigan in Washington State, and we had the same IRB. So that made it much easier, where he could submit it to one, and we had a multi-site IRB, but we had the same. Can kind of go into military, how it's set up, but we fell into the same region, so we had the same IRB board, which is why we were able to do it. Ideally, I reached out to Dr. Paskalski and some other well-known orthopedic surgeons to try to do this, and we just could not get the IRBs to match up. But ideally, yes. I mean, if we could have made this cohort 10 times as much, where we had 800 patients versus 83, which I honestly believe in the military could probably get to in the hundreds. It's just very difficult to do, but I think that would show us so much more.
So Ivan Wong is conducting that exact randomized clinical trial to compare AEGR to Latarjet, and we're actually a center at Utah, and it is an exceptionally difficult study to recruit for, because when you tell the patients this is one treatment and this is the other treatment, they seem so different from the patient's perspective. The patients are like, I cannot imagine you randomly assigning to one of those groups, and patients tend to have strong preferences of either I want my own bone, I want it done arthroscopically, I want cartilage on the graft, I want it to heal more quickly because it's my own bone. So it's been surprising to me how that patients, at least maybe the Utah patients, are more fiercely independent than the patients would be in Los Angeles. I can't imagine that's true, but I cannot get patients signed up for that study. It's really, really hard to do that study.
That's tough.
Yeah.
And you didn't find a predominance. You just found that they would disqualify themselves by their adherence to wanting to have a choice.
Well, we've had a lot of patients that are candidates. I can't get the patients to agree to be part of the study.
Yeah. Did you see that they drifted in one choice or the other more preferentially?
I mean, the challenge I have, and I'd be curious to hear your thoughts on this, because this really plays into, in the military perspective, this becomes very important for return to duty, is with autograft, I'm comfortable to let them return sooner. So Latarjets, I think people gravitate towards, because like this time of year, I saw if I do a Latarjet right now, we can start skiing in January. If I do an AAGR, I'm not going to you're going to lose this season. So that definitely pushes some patients towards autograft. Did you guys have a difference in time to return to duty between these two groups?
We treated it the same. However, if I treated a Navy SEAL or a Special Forces soldier that needs to deploy at a certain time, we're probably, I'd have to look at the numbers, but I bet we were more assertive in recommending the Latarjet because of the data that we can return to duty faster. Now, if it's another physician, I mean, you have all the time in the world. So we might just do give them options. But if it's somebody that I know they're going to go and try to kick down the door and maybe do things that we don't talk about, then I would probably be a little bit more persistent, suggestive of doing a Latarjet in those patients. And that's my bias as well.
What would be your practice pattern, Ryan? Would there be a difference for you in time to return to play, return to duty between those two procedures?
Certainly, and I think that's one of the, unfortunately, crippling aspects of military medicine. It's really hard to engineer longer-term follow-up, and then the patience for a longer recovery process is very slim. And that's military branch specific. So I think Army probably has the most hospitable. They'll typically allot you about a year for recovery. But a free bone block is one that I would probably want a confirmed CT union with stability confirmed and return to sport testing or return to full functional activity would have to be affirmed before allowing somebody to return to that higher level of combat arms.
I definitely agree, especially if you know that they're going to go do something and may not be there around someone that can help them out. So again, I that's why I said the Latarjet to me is not dead, despite what my research shows that is equivalent to me. It's not dead because it provides a lot of security with the current data that we have, all the evidence that the literature has shown that it is a very good procedure.
So Peter and I have just returned back from CESIC, and we were drawing a little bit on the experience of some of our European colleagues that are doing bone blocks in the absence of any bone loss. Is there a threshold above which you will start to consider bone block options? And if so, what is that?
Are you asking what I would do?
Glenoid-based bone loss that indicates it for either an AAGR or a Latarjet.
I think from a AAGR, 15% is where I would actually consider adding an AAGR or Latarjet. And I think when we're creeping beyond 25, 30% is where I would probably not do the Latarjet and just do a very large AAGR.
Well, I think Dr. Codman would be proud of your ability to collect this data and execute that from your individual military treatment facilities. It's incredible, and I can certainly appreciate that's a testament to your hard effort. I just want to congratulate you on your paper. It's great work, and we're excited to see what comes next.
Well, thank you so much. It's an honor to do this, and I really want to give credit to my co-authors, especially Dr. Galvin. He's a huge part of this and made this happen for us.
We're joined by Dr. Peter McDonald of the Pan Am Clinic in Canada, who's going to discuss his paper, Arthroscopic Bankart Repair with and without Remplissage in longer inferior craniocaudal Hill-Sachs extensions, secondary analysis of a randomized clinical trial. Dr. McDonald, welcome to the podcast.
Great to be here.
Joining us as a guest host is Dr. Julie Bishop of The Ohio State University. Dr. Bishop, welcome to the podcast.
Thank you very much.
So, Dr. McDonald, I think a lot of listeners are going to be well familiar with your randomized clinical trial. It's been practice changing. Tell us what you did here, and maybe before that, what inspired you to do this kind of secondary analysis of that data?
Well, we did all this work on the initial trial, which we published 2-year results in 2021 and medium-term results in 2024 for the Remplissage with and without Remplissage with a Bankart repair, and showing that the Remplissage does make a difference in terms of recurrent instability. So we did all this work, and we thought, well, is there anything else we can look at? And we're talking with my fellow Keigo Hanaki, who's our first Japanese fellow, a very analytical guy who's very interested in the Hill-Sachs lesion, and how we could do a secondary analysis of the data that we already had, just kind of farming it, if you will. And he came up with the idea that on reviewing a couple of papers in the literature, one by Lin in Pittsburgh and another Korean paper, that there might be a worthwhile exercise to look at the inferior extension of the Hill-Sachs and whether that makes it a difference in terms of recurrent instability. So that's how we got the idea, and when we looked at the data, there was a difference. So,
and tell us how you measure that. How do you determine the inferior extension?
Well, there's 2 papers in the literature, and Lynn described the technique that we used, and it's called LEA. And what it is you draw a longitudinal axis along the humerus, and then you draw a secondary line through the inferior extent of the Hill-Sachs lesion. And if that's greater than 90 degrees, then we thought, well, that's a long Hill-Sachs lesion, so that's probably more apt to engage. As we all know, the glenoid tract measures more medial extension of the Hill-Sachs rather than the superior inferior. So this is kind of another way of looking at it.
So this is on a sagittal MRI slice?
Sagittal MRI slice.
And you're not looking at all where the top of the Hill-Sachs is. It's only where the bottom of the Hill-Sachs is.
You can look at the top of the Hill-Sachs, but we're more interested where the bottom was.
And what did you find?
What we found is that in the patients who had the LEA greater than 90, they had a huge increase in their propensity to redislocate without adding a Remplissage, in our group without adding the Remplissage. So the data was that in the LEA greater than 90 degree patients, 36%, almost 37% had recurrent instability in the no remplissage group. And that was versus 7.1% in the remplissage group. So highly significant, a 7.5 times higher odds ratio of recurrent instability if you did not do a remplissage.
Wow. So I mean, that's a big difference.
Huge.
I mean, like it sounds maybe then like that inferior Hill-Sachs. First off, I mean, before we talk about the Remplissage, it sounds like with that kind of recurrence rate, that inferior Hill-Sachs, it sounds like is a real bad actor.
It is. I guess, I'm just hypothesizing, but in the abduction external rotation position, it just makes you way more apt to engage that Hill-Sachs.
Now tell us, I mean, do you think this is maybe a secondary marker for size of the Hill-Sachs? Is this like do you think that had you done a 3D analysis that you'd have found the same thing? Or do you think that this is like a very kind of specific geometric marker for something that really adds up?
That's a good question. I think that there's a lot of factors to consider. I think we like easy measurements that are reproducible. So This is an easy measurement that anybody can do. It's reproducible. You can start doing area mapping and stuff like that, but that's a little harder to do. So this is one factor you can look at. Glenoid tract is another. is another. So all these things are things you can look at in terms of the odds ratio with the Hill-Sachs lesion of recurrent instability.
Julie, have you been measuring this in your practice?
So I have to admit, I have not. I was compelled by Albert's paper when I first heard his paper and started to think about it. But we have so many things that we calculate. Sometimes it can be overwhelming to sit down and calculate everything. But then upon reading Peter's paper, it really is compelling that perhaps this is one of the more important things we should be looking at, because it's pretty easy. And obviously we're all crunched for time, and this is one of the more easy calculations to do, that you can quickly look at the sagittal and almost with your eyes see, oh, this is greater than 90, this is something that I should do. So I really think that after reading this and really reviewing the paper, that's something that I will add in.
Some of the things we're obviously consume disproportionate amount of our time and energy is figuring out who not to do a remplissage in. And I've always been a little bit concerned about those more cephalad ones as a constraint to really motion. I think what you've done great here is you've identified the patients who really are ideally suited for treatment here. So at this time, what are your indications for remplissage?
I think that remplissage has become pretty easy to do with newer anchors. It's fast. It doesn't add a lot of time to the operation. So basically, we're doing it on all Hill-Sachs lesions that we see when we're doing an instability case. I don't find a good reason not to do it, to be honest. We didn't find in our bigger randomized study that there was significant differences in range of motion with the remplissage group that persisted past 1 year. So I don't have a good argument not to do it. It's simple, it's easy, it's reproducible, and it seems to make a difference.
Does this affect the way you do the remplissage? Like, does this make you think maybe our anchors need to be a little bit lower when we do a remplissage, because clearly the low part of the Hill-Sachs is the more important part?
Yeah, that's a great question. We haven't changed the technique as a result of this paper, but certainly if you're going to have any technical error in the remplissage procedure, you want to make sure that inferior part is filled rather than the superior part. I would say we haven't changed the way we do it, but that's something to keep in mind.
Can I ask a quick question?
Please.
Because Dr. McDonald, I'm curious, because we've kind of debated this and talked about this, and I'm thinking if the extent of the Hill-Sachs is much more inferior and you go more inferior with your anchors, how often are you to place a posterior inferior anchor on the glenoid? Because you're almost dueling if you're that low with the Hill-Sachs for real estate to place a posterior inferior anchor. Do you routinely do that?
I don't routinely do the posterior inferior anchor, but certainly Antonio Romeo is the one who taught me the posterior inferior anchor quite a long time ago. And I do pay attention to Bankart lesions, which come around to the 7 o'clock position. So if we have a Bankart lesion that goes around and there's a Hill-Sachs, I'll do both. But I do agree that there's a little bit of a challenge real estate-wise with, once you get a big Hill-Sachs lesion and you got that anchor down there, and you worry maybe a little bit more about stiffness. But I haven't seen that, or I don't have any data to support that.
How does this affect, like, when we need to do a glenoid bone graft? I mean, do we look at this and think, okay, well, this is a patient with a low Hill-Sachs, and therefore a Remplissage is more likely to work, and therefore maybe I can push into that subcritical bone loss still with our Bankart? Or do you think that this has kind of no influence whatsoever on your thinking about who needs a Latarjet or some sort of other glenoid bone graft?
Yeah, our original study was less than 15% glenoid bone loss, and we've stuck to that as a number, arbitrary as it is, whereby, if you have greater than 15% glenoid bone loss, we think about doing a bony operation. So there have been a couple of papers that come out and challenge that and say, well, you can actually push that to 20 or 25, but I think the safe thing to do is not to get into high degrees of glenoid bone loss when you do a Remplissage. Just to not expect it to do too much, if you will, to get into Latarjet or whatever your favorite bone block operation is.
From a granular perspective, can you describe for our audience what your technique is?
Yeah, the technique has evolved over the years. When we first started doing Remplissages, it's a big deal. You're going to the subacromial space, you're cleaning off bursa, you're watching your knots go down, and it adds a significant degree of time to the operation and complexity. Now with the newer all suture anchors, we're just basically doing a knotless Remplissage. 2 anchors, all suture usually. Sometimes in a bigger Hill-Sachs lesion we might use 3, but mostly 2. And then we don't go into the subacromial space anymore. And we just shuttle the repair suture from one anchor into the shuttle mechanism, the other, and vice versa. And like I say, unless you get your sutures tangled up or something, which there's ways around, you don't find that it takes that long, maybe an extra 5 or 10 minutes.
And if I could press you on it, what do you think the fate of the Remplissage is? Is it truly filled with the rotator cuff tendon and capsule? Is it just a posterior tether? Is it a little bit of both? Curious about your thoughts and Julie's.
And we had a subset of patients, about a third of the patients in the study, where we did follow-up MRIs, and the fill was pretty significant. The healing rates are pretty significant. More than 75% were completely healed. So I think, and then there's Pascal Bolo's study from 2014, which showed a high degree of healing. So it seems to heal, seems to work. I can't explain why they get their full range of motion back. You start to wonder, well, did it stretch out? Did it come apart a little bit? But that doesn't seem to be the case on imaging.
Julie, any additional thoughts?
I mean, we haven't looked at our Remplissages to see what the fill rate is or to see how it heals. Certainly sometimes if I'm being honest and I'm looking at the repair, I'm thinking, is this truly going to heal? Is it going to stretch out? Is that why they don't lose external rotation? But maybe it's still, even if it partially heals, it is some form of a tether. I'm probably not as expert technique-wise as Dr. McDonald, but I think something heals because it does do something, but I do believe maybe it could stretch out a little bit, especially when you look at the tissue you're tethering in. It's more capsular than tendon, if you're being honest with what you're looking at.
Well, this is great work. I mean, I think it really pushes us forward in our understanding for indications for Remplissage, technique for Remplissage, our understanding of the Hill-Sachs in general and its contribution to instability. So I'm really hats off to you guys for doing it.
Thanks very much. It's our pleasure, and we're reassured by the number of papers that are coming out in the literature that are saying basically the same thing. Not so much with the measurements, but with Remplissage in general, showing the similar rates of reduction of instability with Remplissage with our study. So it seems to be echoed in the a number of papers now.
Great.
Great
Well, have a
work.
great meeting. Thanks for coming.
Thanks very much.
Thank you.
Thank you.
All right, good morning. We're now joined by Dr. Badman of Central Indiana Orthopedics, who's going to discuss his paper, Three-Dimensional Printed Glenoid Components in Complex Shoulder Arthroplasty, Early Clinical Outcomes and Complication Analysis. Dr. Badman, welcome to the podcast.
Thanks for having me.
Joining us also as a guest host is Dr. Nieboer of the Mayo Clinic. Dr. Nieboer, welcome to the podcast.
Hi, happy to be here.
All right, so Brian, tell us what inspired this study?
I think, these cases, where you got a lot of glenoid insufficiencies, I think they're still challenging. I've kind of approached them at all different kind of angles. I've been in practice for 20 years, so, I've seen it with, allograft. I've done my allografts, and I've had failures of that. I've done not as quickly. I mean, for whatever reason, autograft has always been like that. The scary place. You don't want to like re-prep and go to the hip. But I actually, having gone through some of the experience with my customs now, I've actually kind of gone back a little more to taking crest for these. But these are kind of cases where I don't think we've kind of tapped into like what's best. And I think when I've met with a couple of the companies looking at the 3D printed stuff, it was kind of exciting because I think you now have the ability to kind of create a large hunk of metal, more or less, to kind of fill the void that that's missing and created by a lot of these challenging bone loss cases. And my practice is a very tertiary practice, so I get sent like the hardest of the hardest, it seems sometimes. So like some of these patients are coming in and they've been told that there's nothing that can be done. And I think the 3D printing has been kind of a cool new adjunct that we can kind of now look forward to kind of treating these.
Yeah, great. So just lay out the methodology for your study then.
So, the impetus was really to kind of, we wanted to essentially I wanted to look at my, kind of critically analyze my outcomes in terms of like, the patients that I treated with customs. I think it's kind of funny because once you kind of start using something, it becomes kind of the new toy in your bag of tricks, and you're kind of quicker to maybe I'll do a custom for this one versus, not. But I tried to be really critical, at least in the cases that I did. I mean, I thought were, significant kind of deformities where, if you didn't bone graft, they would need something to kind of supplement it because they had significant amount of, lack of vault or whatever when I was approaching it. So I just wanted to kind of look at my subset of patients and can critically look, was it really making a difference or not?
So essentially a single surgeon series over the course of 2 years, and share your kind of key findings.
So I think, when I analyzed, preoperative to post-op, these are, again, a lot of these patients are coming in with very poor, the patient-reported outcomes are usually pretty poor to begin with. We found that all, despite complications that we did have, early on, a lot of the patients all had statistically significant improvement in all patient-reported outcomes, all range of motion. I think that the early thing that I was kind of got a little cautious on, or like gave me a little pause, was, within 4 to 6 months, I did see some screw breakage, and initially I didn't think that was going to be a big deal. And then I had 3 base plate failures, and anytime you have one failure, you're kind of like, man, maybe that's just a one-off. And then I had 2 more where the body didn't ingrow and it kind of snapped at the post, and so that kind of again made me it was really more the impetus was kind of then to critically go back and look at all of my 18 patients, because then you kind of wonder like are the rest of these going to fail? In part of the study early on, I got CT scans on I think 15 out of 18 of the patients that I performed on, and I was able to get a CT scan on all of them within about 6 months of surgery. And then, because the initial study I wanted to do was to kind of see, well, this is how I planned it, this is how I performed it, and then kind of critically map out like, how well did I put the implant in compared to what I planned. So the CT scan data actually early on, we analyzed all that, and we felt that all 18 patients had ingrowth of the central post within 6 months, which was kind of interesting. That then 3 of them went on to failure, where it kind of broke right at the post. So I thought, and then when we kind of looked at, we teased out more. So early on, the reason that there was, if you look at the data, early on, the Restore, we're using Synthes 4 non-locking screws to kind of peripherally compress the graft, or the base plate. They then transitioned to a striker screw, and then they took the manufacturing in-house and then switched to the 5.0 locking screws. And when we kind of broke out the complications, we found that actually when all the failures really occurred with the 4.0 screws. And when we went to the 4.5 and then the 5.0 screws, we kind of eliminated I haven't seen any further failures, so once we transitioned to that. So I think there's definitely, and then we kind of looked at the lengths of the screws. We found that if you had much more longer, like if you added up the length of all the screws kind of used, if you had larger screws and longer screws, it was basically you had a better fixation, and so we didn't see any kind of failures with that.
And so what are your indications now for PSI implants? I think that's something that sometimes I go into it a little bit blind. I get a CT scan, the deformity looks a little worse. Obviously, you're looking at it probably preferentially for more revision, but maybe lay out what are your parameters you're looking at now?
Yeah, again, kind of coming full circle, having had granted 3 failures, I think it's well within what's been previously reported in some of the other smaller. I think to what we were discussing offline, there's not a lot of literature right now in terms of all these customs. It's obviously it's a significant cost. I mean, I think the IU had a heart-to-heart with me, about the cost of these implants, and Dr. Badman, can you use a cheaper implant for some of these? And so I think when I had these failures, I kind of actually took a pause on putting the customs in, because I wanted to then monitor the other 15 patients to make sure that were all these going to, was I going to have 15 failures all of a sudden? So I kind of went back to using, going to the crest a little bit more than I had done before. So I kind of, I think I'm still kind of trying to figure it out myself, because I thought this was going to be a great solution. But and granted, I think 17% base rate failures I think is acceptable, but it kind of begs the question: is that acceptable? Is that a low enough number that we can kind of say, well, it's okay, but I think we can still do better. So
that's in the short term, right? I mean,
and that's kind of what gave me a little pause. Like I said, I literally stopped. I had not done a custom since I had my last failure, because again, I wanted to kind of monitor the other 15 patients. And granted, I have had a couple come back now at 3 years, and they're still doing okay. But the question is, are they going to be doing okay at 4 and 5 years? I recently had a case where patient had a primary, like a regular base plate that I put in. It was when I was using Stryker, came in 6 years post-op, and the base plate had fibrous ingrowth around it. And I think the 5.0 screws in the base plate none of them broke. So I'm so you got to wonder, is it truly ingrowing, or is it that the fixation is going to hold up, long enough, over the long haul? I don't know. I think that's where I think having 8 to 10 year data is going to be important for some of these customs.
And I'm assuming the ones, you'd mentioned previously that you felt like the 5.0 screws had a lower failure than the 4.0 screws, but you don't have as long a follow-up.
Right.
There's a little bit of a time bias within that comparison.
I completely agree. So I'm kind of in that weird, watch and wait window right now, because, again, these, for me, as we all know, these patients are coming here, they want solutions, and unfortunately some of these patients actually initially within the first couple of my patients were doing awesome with the first 12 months, and then they'd come back, and the first one that happened, I'm like, oh, that's kind of weird, and I got a CT scan, you can see the broken post, and then once you have one of these outcomes, you kind of look for it, you kind of oh, there it is, so it's kind of now I'm kind of just approaching these a little bit more cautiously.
When you went back on those patients, was it hard to get the post out?
So the two of them, I actually left, and I was able to kind of work and I went back to just doing a graft and a monoblock, and they did like an alternative spine line technique and kind of medialized the fixation and kind of accepted what I got. The other one, I cored out I had like a trephine, cored it out, created a big chunk of missing bone because it ingrew very well. But yeah, the body unfortunately had a lot of fibrous ingrowth. So, you know, and that now when I do plan, I'm planning another one that I'm gonna do. I am gonna plan a custom that I'm doing for a patient that it's just so much bone loss that I think even if I don't think you could get a big enough graft. So it's like one of those cases. I guess going to your initial question. If I have a case where I plan out and I feel like I can't, I'm going to need such a large graft, I think I'm still kind of willing to now do the custom route. I think when I plan these out, though, I think doing something you have to compress it. You have to somehow achieve a good amount of compression, I think, of these custom implants. Otherwise, I think we may run the risk that we're going to see some failures.
Related to your planning for these cases, talking about, obviously, a lot of these patients are very medialized. What is your goal for lateralization? I've been in a handful of these cases, and the engineers are great to work with, but they will always show you a design that is lateralized as much as possible. Do you think that's asking too much of the implant? Do you try and, put a more medialized construct on the glenoid side?
Yeah, so that was kind of a learning thing too, and I guess fortunately doing 18 kind of in a row, you kind of get to, at least with the Restore, I'd work with one engineer, and he kind of got around my philosophy. Yeah, these are cases I think if you try to bring it back and lateralize it too much, you're not going to be able to get the thing reduced. I actually had a patient where I planned a VRS, and I'm not beating up VRS or anything, but they engineered it, made it, and then sent it, put it in, and I'm like, I had to pull it out, and it became like a $15,000 Christmas ornament I gave the patient. So I'm like, go hang this on your tree, because I can't, it wasn't able to use this today. But so I kind of look at it. I kind of see where the humerus kind of lives and exists, and I don't try to bring the humerus out too much further than on the premorbid, like the planning software I usually kind of put the premorbid humerus in place, and so I kind of look at that where it's kind of sitting, and I try to restore that, maybe a little, kick it out a little bit, but not too much to the point, because if you do, you're gonna have struggle with these. And I think if you put it in too tight, then I think you're also setting yourself up. Maybe there's too much force on the interface to begin with, which is maybe then contributing to failures.
One of the things that I think is really interesting about your data is, we've historically had this idea that we prepare the bone to match our implant. So we're reaming and drilling, and those things are, they expose elements of the bone that are not normally exposed. They create a healing response within the bone, and then is there some of that preparation then that causes the bone to grow into our implants? This is a new concept that we then make the implant to fit the bone, and then you don't do any of that preparation. So it's interesting to me that your posts ingrow, but the failure is the face didn't ingrow.
Right.
I guess the question I would have for you is, does this lead us to believe that if we do use a custom implant, maybe we need to be doing something to the bone still to incite a healing response within it?
Yeah, so even on some of these cases where when I prepared them, I'll purposely try to micro drill. I'll usually have like a TPS burr. I try to do something on that bone, the metal host interface, to get some kind of bleeding. I know a couple of docs will pack some infuse behind it. Again, being conscious the cost. If you couldn't put in a custom and throw an infuse in, I definitely gonna get a call from the CEOs next week. But yeah, I do prep it. But to your point, if you're prepping it too much, then you're gonna actually lose the fit that you planned. So there's that fine line of how much prep is too much, or do you prep it at all? But I go, going back to what you think or what you were thinking, I kind of believe that you got to get something to kind of like incite some degree of osseous ingrowth at the interface. Otherwise, I think you might run a risk of getting this fibrous ingrowth, fibrous healing.
And particularly as your points of fixation move more medially, I worry about transferring the stress upstream. I've seen a handful of patients that have come back with scapular body fractures, and these are complex scenarios. Did you encounter any of that in your study?
Yeah, so one of the complications I did have was a lady that had a scapular spine fracture, which occurred. It cracked at 4 months. It was a Levy 3. She actually did okay with that complication, and then she was a twofold complication, because then she ended up having a snapped her post. So it was kind of interesting because the scapular spine fracture kind of ended up tilting the construct superiorly, and then the post snapped, and that she snapped at 18 months post-op. So
Micah,
kind of double whammy complication.
Yeah.
So
Micah, you've had some unique perspectives now traveling around Europe. Are there complementary experiences you see over there? How are they handling some of this?
Yeah, so I think at least where I am in Central Europe now, of course, they're big believers in bone graft and bio-RSA, and they're doing that for most of it. Now, one of the earlier studies from the UK for custom implants, that was one of the larger series that I know your paper cited as well, and they had quite good outcomes. I think something that they were doing in that one specifically is that they were often adding like outrigger to the coracoid. I don't know if you had done that in any of your designs. That was something they would frequently add for extra fixation. Had you used any of those in your?
I have not, but again, I referenced ProMade. That was been recently available in the States, but I've seen kind of some of their apparatus or some of their designs, which have been quite interesting, and I'm curious if that's because they do. I mean, their complication profile is definitely one of the lower complications. Like I believe 7%. They report. I think their implant failures, I believe, was like 2.4%. So quite impressive. It was a fairly large series of patients. I think like 62 patients they kind of reported on. So you wonder if maybe offsetting some of the load might help with some of these implants. I don't know. Again, I think this is the opportunity where I think we're kind of learning. I think the 3D printing is definitely. I mean, it definitely is a viable option. I think the cost will continue to kind of come down. They have to come down because there's no way. It's not a sustainable practice if you're going to use $15,000 to $20,000 implant for these patients. But I am curious. Is that gonna, are some of these different struts and things helpful?
One of the things that I think is interesting about the cost is, traditional our implants have been made, in highly controlled factory settings with validated machines that produce those implants all day long. But 3D printing, I mean, you can actually commercially buy a titanium 3D printer. These could be produced locally and then machined and sterilized, and that could bring the cost down dramatically. And if it's something where the technology is just software and we as surgeons could design them, I mean, the question then becomes, is there a future in which, maybe we don't have that same central distribution model and we have more of a kind of local distribution? But you've done 18 of them. Now I'm sure you've worked with a lot of designs. Do you see, as you've gotten more and more experience, does it seem like you as a surgeon could interact with the software that could design it? You would not necessarily even need an engineer?
I mean, I think I'm sure through AI and machine learning. I mean, I think you gotta want to. I mean, because I think that's again would be the more people kind of plan these out, I think then you kind of, with AI and machine learning, you kind of figure out, okay, this plan worked better than that, and because I think even now Stryker is kind of using their pseudo custom kind of thing where add a little bit more metal to it. I think I believe that at some point that's going to happen, and it's probably going to happen sooner than we know.
That would be a dramatic difference in the way that we produce our implants.
Right.
Yeah, and obviously the biggest limiting factor is having to take it to the hospital and insurance carrier approval. Obviously, you can take a big haircut on this. Do you think there's any future otherwise to make the transition to the ambulatory setting for some of these procedures?
being a owner in my own private ASC, I mean, this would kind of flip you upside down really quick. Yeah. So yeah, I think it's going to have to come down, and I think it goes down to just the processes and bringing things in house, and my understanding is like to 3D print something can be relatively cheap. It's more like the engineering and the cost of the tool, that and the that kind of escalates the cost of things. So I think right now it would be very hard to kind of do this in an ASC just for the sheer fact it's just too expensive.
Right. Look, I think this is really important data, and I appreciate you sharing your experience. I mean, it's really I think there's a lot of people pushing for it to be the future. So it's really valuable to have your voice to say, this has been my experience. Maybe hold your horses and follow your patients and see what happens.
Right.
Yeah.
Right. Yeah, and I don't want to say that. Like I said, I'm actively learning. So
as are we all.
Yeah.
Well, thanks for your time.
I appreciate it. Thank you.